Today I wanted to talk to you about individual health trajectories and the relationship that they have to population health trajectories. In particular, after the talk this morning by Rob Warren, I realized I should have used either the WLS or CDHA logo for this instead of this figure. But oftentimes, when we think about what the aging process looks like, we find ourselves with competing intuitions that we don't often consider. So on the one hand, when we think about aging as sort of like our popular image of it or what it happens on a population level, people often think of aging as a time of gradual decline in health and function, right? This notion that you see reflected here in kind of like the curvature of the base, right? That there's just this kind of smooth transition into old age that comes along with some kind of decline in health, and that's very intuitive. On the other hand, when we think about individuals that we know who are growing old, ourselves, other people in our lives, we know that when we think about their health trajectories, it's not necessarily a very kind of smooth, uniform pattern of health declines. Most people's health is kind of steady until something happens, right? And oftentimes something does happen, but people experience recovery. That's pretty frequently the case. People might sort of go up and down for a while. And there are also sometimes cases when, if you think about mortality coming sort of at the end of life, it doesn't always come at the end of a long, slow period of decline. Sometimes it can happen suddenly, too. And so there are these competing intuitions about whether aging is really this smooth, gradual process or this process of individual events. And as researchers in population aging, a really sort of compelling way to think about reconciling these two intuitions is to say, well, one of these is an individual level process that's kind of messy and hard to predict and goes up and down. But on a population level, patterns of health and aging are probably more likely to be gradual. They're smooth. We average over a lot of people. Sure, there are changes, but overall, right, as people get older, they may have more health problems. They have more functional limitations. And so it makes sense to think of perhaps reconciling these two things in that way. And I'm going to argue that that is appealing. In fact, as population health researchers, we generally tend to use data that individuals report to us in surveys in order to make inferences on a population level. And we do that because we don't just want sort of the very messy heterogeneity of lots of individual stories. We want to be able to say something systematic about differences between groups of people and how particular kinds of exposures are associated with more or less risk of poor health in later life. And the question that I am going to pose to all of you today is, but what happens when we make these assumptions and it turns out that looking at individuals and looking at populations is not reconcilable in this way, but actually suggests that there are two different kinds of intuitions and that they mean that we should think differently about how population health unfolds and about what that means for how we understand inequities in health on a population level as well. So I'll tell you a little bit more, and I'll try to do this quickly too. And so the assumption that I'm especially interested in and kind of in how we characterize patterns of health change over age and in later life, I'm going to call it gradualism. This idea that you can draw a smooth trajectory that reflects the notion that changes in health accumulate sort of steadily and continuously over time. This is, I think, a really appealing assumption, one that we don't question very often because fundamentally it's biologically very compelling. Right? Health probably does change in an incremental fashion over time, and it's only if it reaches some kind of threshold that's when we would really notice a big change. It's also, as you know, many of us are folks who like to model things statistically, assuming that health changes gradually has really appealing statistical properties because we can model it using functional forms with parameters. Right? And that means that we can also ask questions, generate clear hypotheses, then we can test them using statistical models that we're all very comfortable with in order to kind of say, right, how is this risk factor X associated with the changing pattern of health in later life. But I think there's a tension here in making these comments about how health changes on a population level because we are collecting data from individuals, and because although health subclinically may or may not be changing in sort of a continuous incremental fashion, we actually check in with people in a very discrete way, right? In most longitudinal health surveys, we check in with people maybe once every few years, once every year, once every 2 years, once every 7 years, depending on the survey. And so there's a question that we don't often ask ourselves about the extent to which this assumption of gradualism, and then this is how health changes, is consistent with the data, right, and the health processes that generate that data. And then in turn, if there is an inconsistency, which I'm going to give it away and tell you, I'm going to argue that there is, if there's this inconsistency there, what does that mean for the way in which we understand disparities in health by things like race and socioeconomic status? And so I'm going to show you some just really simple examples of what happens when we look at patterns of health using the Health and Retirement Survey. Right? So the Health and Retirement Survey is a nationally representative sample of older adults. It's probably the most frequently used data source to study the health of older people in the United States. It has been going on for a really long time. We've been following people since 1994. We check in every few years. The HRS collects a wide variety of information about people, about their health, about their social well-being, about their economic well-being. Here I'm going to use almost none of that rich data because I am going to just show you what happens in terms of the longitudinal trajectory of people's health using this measure of functional limitations. Right? So functional limitation is a sum from 0 to 12 of these various mobility measures, and I'm using it rather than something like the count of chronic diseases, which we often think is what may underlie functional limitations, or something more severe like limitations with activities of daily living, which is a more extreme case of disability, because if any measure of health that we collect longitudinally over time is going to display a gradual pattern of slowly accumulating over time, it's probably going to be functional limitation, right? People do have multiple chronic diseases, but people usually develop certain chronic conditions, and while comorbidity is a big deal, we don't sort of expect people to accumulate more and more and more morbidities over time. You kind of have a few for a long time, right? Maybe you'll have one, you'll develop one more, but there's not sort of this assumption that things will get gradually worse and worse. And on the sort of other end of the spectrum, likewise, disability isn't something that we kind of just anticipate becoming more and more severe. But functional limitation is this in-between state. It's just people having a little bit more difficulty doing some of these basic things. And so if something is going to gradually change as people age, this might be it, right? What we did in this project is we tried to model the pattern of health over the life course using 5 different methods, some of which have an assumption of gradualism built in. So these are very popular models like latent growth curves and latent class analysis. You heard a little bit of critique of these models earlier this morning, so perhaps you're already a little primed to think that these are perhaps not quite as informative or as enlightening as they might be, but nonetheless, for folks who try to model patterns of change longitudinally over the life course rather than just thinking of health at a single point in time, these are now really popular models. They allow you to use all of the data that you have and really draw a picture of what happens to health over the life course. And if you use the HRS to look at the pattern of health over the life course, then you see that for the population average as a whole, there are parameters that estimate heterogeneity on it, but in general, people who use these methods tend to report these kinds of patterns. You see that the population on average starts off with very few functional limitations, and there is a very slow but gradual increase in the number of functional limitations across survey rounds, right? As the cohort gets older and we expect sort of poor health as measured by functional limitations. So that's one way of thinking about what happens in the population, but then people often say, well, this is assuming a single population average trajectory is going to characterize the whole population, but people are diverse. There could be lots of different trajectories. Not everyone has to follow this pattern. And so another way of modeling this over time is using latent class growth analysis, which says, okay, well, let's use the data to see whether there will be classes of trajectories. Maybe there are multiple types of people, and we can characterize this, right? So there are a lot of people, the majority still fall into something that looks kind of like we saw for the population average overall, starting at a very low level and increasing over time. And then we have some folks who start at a higher level, higher still. There's one group of people that really do show a very rapid increase in trajectories. And now this allows for more heterogeneity, which is something that researchers on aging have been interested in a long time, thinking about heterogeneity in the aging population. But it still assumes that all of these trajectories are gradual. They're still all parametric processes. It's interesting that when you start dividing this up, with the exception of this class C that increases, a lot of the other classes are actually characterized by stability. There's not really that much change, but to the extent that there is change from where people were in the beginning or the end, that change is smooth or continuous over the entire course of follow-up. But it's sort of weird. There is that class D over there that looks like it's improving. It starts off with really a large number of functional limitations, but it gets better over time before it increases. That might lead us to suspect that this isn't just simply an aggregation of individual trajectories, but that there's something that as demographers we would become suspicious of in terms of the effect of composition, right? What's happening in this group is probably not a whole bunch of people who start off with a high level of limitations, get a little bit better over time, start getting worse, but what might happen is selective change in population composition, right? So the people in that higher group may be the ones who are the sickest, who are least healthy. Maybe it's getting better over time because people are systematically dropping out of the study, either due to mortality or other kinds of attrition that creates the appearance of things getting better before they get worse. But we don't really know. As folks mentioned this morning, these categories are a bit of a black box. We just kind of assume that they characterize the population. So what's going on? And so we decided to go old school and just look at some descriptive patterns of what is actually happening to individual health over time. How many people in the HRS really do experience a gradual increase in functional limitations from one survey round to another? Well, it turns out that, exactly nobody experiences an increase in functional limitation every time the survey checks in with them over the 12 years, the 12 waves that we've looked at. And almost nobody experiences even 8 or 6 or 5 or 4. In fact, the majority of people don't experience more than 1 or at most 2 increases over time. There are very few with 3 and more, right? So this idea of kind of successive increases in functional limitations over the full range of the survey, that doesn't really happen. But really, if you just look at what is happening over time, and I apologize, this is probably hard to see, what you'll see is that if you just compare the first and last round where people were observed, you'll see that there are a bunch of people, right, 60% of the sample who experience an increase in limitations between the beginning and the end, but there are 25% of folks who are at the same place the last time they were observed as they were the first time, and there's 16% of people who are actually better at the end than they were at the beginning, but the population level trajectories don't show us that, right? Now, first and last is sort of a rough old school measure, so what about experiencing any change over time? It does turn out, if you look over here, that most people really do experience some kind of change over time. There are not that many people who don't experience any kind of change, but about 9% of the sample. But there's also a lot, 44%, who experience some kind of recovery or better health at various points, and these smooth, gradual trajectories are not telling us about that. And so we also, right, looked at, again, going back to our formal demographic roots, at a multi-state life table that looked at the way in which people move between different categories of transitions, between simply missing information in a particular wave all the way to an absorbing state of dropping out of the survey for good or death. And when you look at this, again, it's a lot of information. I'm going to try to go quick, but if you look across the diagonal, this is divided up in different rounds because computationally we had to look at chunks of time, but if you look at the diagonal, those are the largest numbers, 75%, 55, 60, 52. Those are the people who just stay in the same category, in the same state of limitation categories as they were before. And there are some folks in sort of the upper diagonal of each table that are getting worse, but there's also a lot of folks who are getting better from time to time. And so the situation of what individuals actually experience over time, even when you aggregate it this way in a population, is more complicated than this notion of a smooth increase in poor health measures. And so I wanted to show you just a little bit of what it looks like. These are 50 just randomly selected trajectories of respondents in the HRS and what their health patterns look like. They're all over the place. They're super heterogeneous. It's hard to say that there is any one particular patterns. People go up, people go down, some people increase. A lot of people, if you notice here, we've got 0, 1, and then we have missing, attrition, and dead. A lot of people are kind of steady until they drop out of the survey, or they're steady, we don't see them for a while, they come back. It's hard to argue that the thing that best characterizes the population of respondents in the HRS is some kind of smooth, gradually increasing trajectory of health, right? In fact, when we ran a sequence analysis to try and figure out what are the most common longitudinal patterns in the HRS, the most common patterns, and again, there's a lot of heterogeneity, so there's an issue here of, are we seeing big patterns or just small groups, but the most common trajectories are flat, right? People stay the same until they drop out, or people are at 0 or 1 and then they're missing, or people die. And so then we said, well, what about, this is maybe really affected a lot by the degree of attrition over a long time in the survey. What if we look specifically at people who see an increase at some point over their time in participation in the survey? And so these are the most common trajectories with increases, and again, they're still pretty flat. There's an increase, often it's followed by a decline, or there's an increase and then people drop out of the survey again. And so it's really hard to make a case based on this that individuals are well characterized by this gradual population trajectory, and it's true that the population trajectory overall shows gradual increase on average over time in functional limitations in the population, but that seems to, in some very important ways, not accurately reflect what individuals experience over time. What we see for individuals mostly is a lot of no change. There's a lot of stasis. And it's not that change doesn't happen. It actually happens pretty frequently in the samples overall. But for individuals, it occurs pretty rarely. And when it happens at different times, in different directions, at different paces. And so rather than thinking of health change as a gradual process, what we argue in a paper that's coming out soon in Demography is that it's better to think of individual health trajectories as following a pattern of that we call punctuated equilibrium, borrowing a term from evolutionary biology, right? So meaning a lot of steadiness until there's some kind of big change. But the question is for the next sort of piece of this is that the reason people really like gradualist models is because we can ask really important questions about the ways in which different kind of exposures at various parts of the life course, about the way in which social inequality in sort of a broad structural way influences health inequities. Can we still do that in a model that is based on this idea that there's just a lot of heterogeneity and it's hard to model it using smooth models? And so in the sort of little bit of time that I have, I just want to quickly show you sort of a new way that we're starting to think about this a little bit, and that's by actually going broader rather than more refined. So we're what I'm going to show you uses this new measure that combines functional limitations in activities of daily living, and subjective health status over the full range of observation time in the health and retirement studies. And we look at just kind of 3 types of outcomes. One, whether anyone has experienced an improvement in at least one of these measures of health and no worsening in any of the others. Another is whether there's really no change in anything. And then the third is a decline in at least one of these measures of health. So these are meant to be broader measures of health that are giving up sort of the granularity of looking at change from one point to another, but really thinking about categorically which people are getting better, which people are staying the same, which people are experiencing a decline in health over the time point. And the interesting thing is that patterns of disparities, at least by race and gender, in these global health measures don't mirror patterns of disparities in mortality. So here, compared to the same gendered white counterpart, black men and black women are less likely to experience health decline, less likely to experience stable health. They are more likely to experience improvements in health, even though at the same time, they're also more likely to face premature mortality. Right? So these things are counterintuitive. It's not, we would expect worse health to go along with mortality, or in stasis, or better health to go along with lower mortality, but that's not what we're seeing in the HRS overall. And in fact, if you then compare this again, but looking at folks who managed to stay in the sample due to good health and avid participation in all 12 rounds, in comparison to folks who were lost to follow-up and folks who have died, you can actually see that we observe poorer health trajectories for those respondents who actually stay in the survey for longer. Right? So people who are more likely to drop out and people who are more likely to die are more likely to look like they have better health, because in some ways, even though we want to think based on cumulative disadvantage frameworks that poor health is a marker of disadvantage, in some ways you have to be privileged enough to live long enough to experience these health declines over time in order for it to show up in the survey. Right? And so the implication here is that right? Not that race in and of itself or gender in and of itself cause these things, but that as these demographic characteristics are markers of exposure to unequal treatment over the life course, these things are influencing inequities in health rather than in mortality by shaping the composition of the cohort that actually survives to successively older ages, right? And so these factors are really informative for predicting mortality, but not necessarily the pattern of health, because the pattern of health isn't just kind of moving in parallel to what happens in mortality. And it also suggests that although much of public health is interested in interventions that try to improve health or to stop health decline, right? Get people to exercise or to develop certain kinds of habits that will slow the process of health decline in later life. In some ways, right, interventions that try to deal with the social determinants of health, which we know are really highly predictive of mortality, might have a bigger effect on population health overall. So, thank you. Questions now? Yeah.
Just a quick question that I'm sure you thought about. So when you have the relative measures improve, got worse, stay the same, I think that's obviously super intuitive when you get around the black box problem a little bit, but baseline health is obviously important. Are you sort of starting with people who are all zero on all of these? No. Or how do we think about this in terms of the racial disparities and all of this?
Right, and so what's really interesting is that so a lot of analysis in health disparities now uses these trajectory models, latent class or growth curves, and what they do when they look at disparities in race, and often they use an intersection of race and gender, sometimes nativity as well, what they usually tend to show is there are differences in baseline health by race, right? So the intercepts are a different place, and black populations often start at a higher intercept, worse functional limitations. But then interestingly, what they tell us is the slope over time, especially when they're using the HRS, right? Because this is the data set they're using, there are differences in